Hi everyone, my name is Kyle Dealman. I'm the project coordinator for the Mental Health and Addiction Initiative here at the Registered Nurses Association of Ontario. And it's my pleasure to welcome you to our webinar today, Identification and Aftercare of Trafficked Persons in Ontario, What Healthcare Providers Need to Know. It's my pleasure to introduce you to our presenters for the day, Mia Biondi, Jenna Baronet, Julie Neubauer, and Carolyn Pugh-Roberts. We're just going to go over a very short bio for each of our presenters before we begin today's presentation. Mia Biondi is a registered nurse with a special interest in increasing healthcare provider awareness and knowledge on human trafficking issues in Canada, as well as organizational readiness to identify and provide aftercare for trafficked persons. Before beginning a career in nursing, she completed a PhD in microbiology and immunobiology studying HIV drug resistance and postdoctoral fellowships in viral hepatitis and emerging viruses at the Sandra Rotman Center for Global Health and the National Microbiology Laboratory. Following her BSCN, Mia worked as the clinical coordinator at All Saints Church Community Centre in Toronto, providing comprehensive trauma-informed care for trafficked youth and drop-in health services for street-involved persons. She also has clinical experience in public and sexual health, severe and persistent mental health, and pediatrics. Mia is now completing the primary healthcare nurse practitioner certificate at Western University and is an active member of the London Anti-Trafficking Committee. Human Trafficking Committee. Jenna Baronet worked as a registered nurse in the emergency department as well as a nurse examiner on the sexual assault domestic violence team in North Bay for 4 years, which is where she was first exposed to human sex trafficking. Jenna is now a primary healthcare nurse practitioner with her Master's of Science in Nursing and spent most of her research courses reviewing literature on healthcare needs of individuals who are trafficked for commercial sexual exploitation. She is now working part-time at the Grand River Hospital in the Emergency Department in Waterloo, Ontario, and continues her research in human trafficking. Jenna Neubauer is Covenant House Toronto's Manager of Human Trafficking Services. Julie provides support and supervision to the agency's 2 HTSE advocates as they manage an active caseload of 72. She is responsible for the implementation of 2 specialized crisis beds for survivors of human trafficking and sexual exploitation within their residential crisis shelter. Julie worked as a sexual health educator and counselor at the House Community Health Centre before joining Covenant House 15 years ago. She's an accredited Ontario teacher and holds a Bachelor's of Education from University of Toronto and a Master's of Education, Gender Studies from University of London, England. And finally, Carolyn Pugh-Roberts is a survivor of 8 years of sex trafficking through strip clubs in Ontario and along the 401 corridor. As an executive member of the London Anti-Human Trafficking Committee, she focuses on advocacy and educating others. She has spoken publicly to thousands of people Canada-wide, including advocacy groups and frontline providers. She speaks at John School, a court-mandated program for men who are arrested for buying sex services, and at the other end of the spectrum, runs a sex worker drop-in at Safe Space for Women in London, Ontario. She has also been an advisor on training packages for frontline providers for the provinces of both Ontario and British Columbia. She is a recipient of a Queen's Diamond Jubilee Medal for her work in this area and currently a social work student at Fanshawe College. She aspires to pursue a career providing care for women in the sex trade and trafficked persons. So at this point, I'm going to pass to Jenna Baronet, who's going to begin our presentation. And Jenna, you just might have to take yourself off mute, *6.
Hello, you can hear me now?
Perfect, yes, thanks.
Okay, I'll just change this slide. Okay, so what is human trafficking? So human trafficking has been defined as the recruitment, transportation, harboring, and or exercising control, direction, or influence over the movement of a person in order to exploit them. So this can happen within the same city the individual lives in, or it could mean that they are being trafficked provincially, nationally, and or internationally. With regards to international trafficking, it could mean that they may have legal immigration documents, but they may have had them taken away from them upon arrival, and now it's instilling fear that they are living here illegally, or it could mean that they were smuggled here and they are now being trafficked. Okay, so domestic versus international. So a lot of times trafficking is thought of as an international phenomenon and think that this doesn't happen here, it happens over there. And yes, this is true. It does absolutely happen internationally. However, trafficking does exist within Canada, within the province, and within your own city. So with regards to defining it, domestic trafficking includes anyone who has been trafficked within Canada. So it does not matter whether or not they're citizens of Canada or what their status is within Canada. If they're being trafficked in Canada, then they're classified as domestic trafficking. So they don't cross any international borders. With regards to international trafficking, it includes any person who has been trafficked across international borders, regardless of what their status or citizenship is. So some Ontario statistics. So the Alliance Against Modern Slavery is a not-for-profit organization that focuses on research and education to help end slavery. In 2014, the Ontario Coalition Research Initiative published a report on the incident of human trafficking in Ontario. In this report, it identifies that during a 3-year period between January 1st, 2011 and December 31st, 2013, there were 551 cases of human trafficking in Ontario. 63% of the victims trafficked were Canadian citizens and 38% were born in Canada. It revealed that 69% of trafficking cases were of sexual exploitation and 90% of the individuals trafficked were females. The majority are between ages of 15 to 24 years old, with 18.2% being 17 years old at the first act of exploitation. However, they did identify that the youngest individual in the research was a 7-year-old. All right, so different types of exploitation that we see in Ontario. It consists of forced labor, sexual exploitation, servitude, forced marriage, and forced illegal activity. So forced labor can be found in agriculture, farming, factories, restaurants, construction, grow-ops, nail salons, and anything with hospitality. Sexual exploitation can be found in escort services, nightclubs, strip clubs, bars, brothels, massage parlors, private parties, residences, pornography, and internet ads. Forced marriage, as per the report of the incident of human trafficking in Ontario, they did identify that there was 219 cases of forced marriage in Ontario, and 25% involved were people between the ages of 16 to 18 years old. Forced illegal activity is essentially people being forced to do something illegal, so petty crimes, theft, etc., because they are being threatened as they may need a place to sleep or eat. One thing that the chart does not talk about, though, is trafficking organs, and this does occur in Canada and is something that is important for healthcare providers to be aware of. Okay, so why or how is this happening? Well, there is a push and a pull factor that not only includes the individuals who are being trafficked, but also the traffickers. When we break down the push factors, for example, we look at poverty, not only for the victim, but also for the trafficker. And by that, I mean from the perspective of a trafficker, maybe they live or have lived in poverty, which is a push factor, and now they're looking for a better life, more money, which are pull factors. So they get involved in trafficking to achieve this. From the victim's perspective, you might have a young individual who lives in a group home or has never had any consistency in their life, and they meet someone who is interested in them and is now showing them love, promising them a better life, a beautiful house, marriage someday, or someone who's coming to Canada to get away from a war-zone country to seek safety and a better life and end up getting trafficked. Most of the time it is focused on victims, which, I mean, it should be. However, there is a broader perspective that it very much is a cycle that can be seen with the push-pull theory for traffickers as well as the individuals being trafficked. I don't know if I can change the slide. Okay, I think it's Mia now.
Okay, so hello everybody. I'm going to talk a little bit about who are our vulnerable populations in terms of being trafficked. So one would be migrant workers, and this is especially if they attempt to stay in the country after their work permits have run out. The next group is newcomers to Canada, whether that be with appropriate documentation or not, they're quite vulnerable to being trafficked. We know that our socially or economically disadvantaged persons, specifically homeless people, are easily recruited into this environment. We really can't talk about human trafficking without talking about the legacy of residential schoolings, and we do know that many Aboriginal persons in Canada are trafficked from their local community down to the urban population. LGBT are also at risk, although currently in Canada we don't have these exact numbers. However, we do know that in a city like Toronto, 40% of our homeless youth are LGBTQ. And then finally, just youth in general, especially youth who have experienced sexual or physical abuse, perhaps have a history of complex trauma, which means many different traumatic events in their life, or have mental health and addictions issues. Just on the right there, I want to talk a little bit about a study from just this year, actually. And this is an American study that looked at domestic sex trafficking in minors. And what I have highlighted there is just specifically that having a previous history of psychiatric issues can make someone vulnerable to trafficking, among many other things that are highlighted there. Just a little bit more about youth. So youth within the Alliance Against Modern Day Slavery study were highlighted as a major group. Most people who come into the trafficking world are initially trafficked between the ages of 14 and 22. 50% of them actually have no history of ever being involved in sex work or sex trafficking. Most say that they have low self-concept. And then, as Jenna pointed out, there has been some instances of minors who are actually trafficking other minors. So how does trafficking happen? Well, Jenna talked a little bit about the push-pull factors, but there's actually a sort of cycle of the process. So the first step is recruitment. And where would people be recruited from? So there I have a picture of the downtown Eaton Centre in Toronto, but recruitment can basically happen in malls, parties, bars. There's been instances where people have been recruited from shelters, schools, youth hangouts, or youth centers, and then major centers of transit also, so bus stations, train stations, and airports. And it happens through some sort of connection, so through friends or acquaintances. There's the Romeo interest, which Caroline will speak a lot about, so a boyfriend or a girlfriend. Could happen through family members. So there are some instances in the East Coast that have been documented of family members trafficking family members through the internet and obviously social networking. Again, some high-profile cases in Ontario about somebody being recruited off of Facebook, and then newspaper or classified ads. And these relationships happen because the trafficker actually gains trust. So there's often a promise of money, material items, presents, food, perhaps nice places to stay, nicer than where that person is currently living. So they may have a difficult home situation, and this is a better option. They also do it for a sense of belonging, so getting that attention and that love, which again they might not get in their normal situation. And then to help resolve any loneliness or isolation that they might be feeling, this might be infrastructure-related loneliness, but could also be an emotional or a barrier to feeling connected to something. From that point, the person is isolated and or transported, so that could be from province to province, from city to city, or even within the same city, but they're being either physically or emotionally isolated from their community. And then finally, the big part, which is the exploitation. So after somebody has gained trust, they've isolated the person, and then the exploitation begins. And this is a complex process, but we've talked a little bit about how this could be labor exploitation, sex exploitation, and so on and so forth. So what do we think is the main method of recruitment in Ontario? Well, the Alliance Against Modern Day Slavery study did demonstrate that being recruited by a boyfriend or a love interest was the major method of recruitment. Second to that was a friend's visit, so somebody coming to visit the victim and then them getting wrapped up in the sex trafficking. Now, one thing that people often mention is that they think that trafficked persons are actually confined, so that there's a physical barrier and that they are confined to their environment, and that's why they can't get out of being trafficked. However, the same study in Ontario showed that actually most people who are being trafficked do not actually live with their trafficker. So only about 6% of persons in this study actually lived with their trafficker. So with that in mind, if they're not being physically confined, although again that does happen, why else might they not be able to leave their trafficked situation? So one reason, and a big reason, is an intimidation or a fear of repercussions. So perhaps there have been threats that there would be harm to the person who's being trafficked, but also that the trafficker knows their friend and their family, they know where they live. There's even some instances of threatening to hurt pets. As I mentioned, there's an isolation piece, and that tends to be a social isolation. There could be some substance use or dependence, but that is not always the case. The person who's being trafficked may or may not have had some self-destructive behaviors in the past, so they may have engaged in self-harm and may continue to do so while they're being trafficked. Some persons who might not be familiar with law might have a fear of law enforcement because they might have committed a crime while they were being trafficked. As Jenna mentioned, there are instances of trafficking for petty crime, and then they might fear being arrested or deported if they don't have status in Canada. There are many other things, but the main one I want to drive home is that most folks who are being trafficked don't actually understand don't want to perhaps acknowledge that they're being trafficked, and then there's obviously a significant amount of shame that people might feel being involved in sex work. So how does this apply to the healthcare setting? Well, one U.S. study from 2014 demonstrated that 99% of sex trafficked persons had at least one health problem while being trafficked. And I don't think for any of us that's a shock. But what was really surprising was that in a study in 2015, this group had demonstrated that 88% of trafficked persons had a direct encounter with a healthcare provider while they were being trafficked, and they were not recognized. So this study sampled nurses, physicians, nurse practitioners, PAs, social workers, and actually patients and families that were at multiple hospitals and medical clinics in urban, suburban, and rural locations in Wisconsin. One of the main reasons that providers felt they weren't able to identify trafficked persons, as illustrated in this bar chart, is that there was a lack of training on sex trafficking. So they didn't feel prepared to identify somebody who was being trafficked. And the other thing I want to point out on that figure is the third point. So the other main reason to giving care to somebody who might be trafficked was the lack of organizational policy or guidance. So they didn't feel their organization had a good plan, they were well prepared, and they kind of didn't know what to do next after they recognized this person. So which clinical settings might we see trafficked persons in? Well, there's not an extensive amount of Canadian data, although there are some studies from social workers and so on and so forth that have highlighted some locations. But in the U.S., there was a comprehensive study that demonstrated that basically trafficked persons can be anywhere. So emergency settings, family planning clinics, primary care, CHCs, prenatal care, obs-gyn, pediatrics, essentially anywhere. Not surprisingly, the majority of these persons were identified in an emergency department, but just to throw it out there that might be because those providers had received the most training compared to some of the other clinical settings. So before we talk about a case study, it's really important to talk a little bit about what trauma-informed care is. So just to say, please be trauma-informed when approaching anyone in your population, but especially if you might suspect somebody's being trafficked. So trauma-informed care recognizes the effects of violence and victimization on one's development, health, and behavior. So a few key points about how to be trauma-informed. So please establish a rapport with that person. Make sure to really self-reflect and be non-judgmental, and be culturally sensitive, knowing that different people have different experiences that make them up as a person, and we need to respect that. please be flexible and holistic. So some organizations have a process, for example, the flow of the emergency room. Well, this might not work very well for a trafficked person. So please do what you can to be flexible in that environment. The biggest point here that I want to bring home is that we need to respect the decisions of a trafficked person. So let them decide how and when they want to receive care and help. They might not be ready to be out of their trafficked situation, but if we use strengths-based approaches and empowerment strategies, perhaps we could identify them and play a part in helping them to leave their trafficked situation. And then specifically in things like documentation and when we're reporting to our colleagues, avoid language that we typically see in some mental health settings or situations. So avoid language like attention-seeking, manipulative, and needy. Instead of saying manipulative, for example, you might say they're just trying to meet their needs in the best way that they know how. Okay, so a few common presentations or differentials that you might see in your environment. So I've tried to group them a little bit, but one presentation might be that somebody comes in, wherever that clinical setting is, dehydrated, experienced fatigue, or malnourished. Another set of common presentations might be that someone presents as pregnant, and that's their main concern. Perhaps they have an STI, they might have been a rape victim, or maybe you might get an inkling that this person is experiencing domestic violence. There's obviously several mental health presentations, so depression, generalized anxiety disorder, bipolar, borderline personality, suicidal ideations, etc. This person might have a history of being addicted, or they might be charting that this person was addicted at one time, or they might be presenting as homeless. Then there's some dermatology common presentations, so they might have burns, branding, cigarette marks, abscesses. Many people will not seek care until the very end, and they might have a complicated abscess. There might be some unmanaged wounds and branding, so tattoos or infections. And then just to the right side of the slide, there's a whole slew of other common problems. So we know dental issues are a major problem that obviously lead to things like endocarditis, minor or major injuries on the skin, fractures, internal bruising, presenting with an unmanaged chronic illness. So in that circumstance, the provider might ask, well, if you know you have diabetes, what has prevented you from seeking care up until this point? They might present with an infectious disease such as tuberculosis, or they might be having issues of organ failure, and that would be indicative of organ trafficking. The other thing that is commonly seen is somatic symptoms. So for anybody that's not familiar with somatic symptoms, these would include things like chronic headache, chronic GI issues, and so on and so forth. And the thing to keep in mind here is however they present or whatever you have in your notes from their history is only one part of this person. So they might have HIV, and that might be documented in your history, but what else is going on with them? Or we might know that they have depression, but what else is going on with them? Pass it over to Jenna.
All right, so some health history, so some screening questions. So these are just some examples of questions that are from the Fraser Health training. However, there have been others published that are used for screening questions as well. But this just kind of gives you an idea of questions that you could start thinking about and start asking if you are concerned about a patient or an individual that you are seeing. It is so important, though, that you make sure you're asking these questions in private so that the individual is by themselves, because they may not answer you openly or honestly if they have somebody else in the room. So just some different examples, have you, been physically harmed? Where do you sleep and eat? Do you have control over when you sleep and when you eat? Are there locks on your doors and windows? Has anyone threatened your family? Has your identification or documents been taken away from you? And in the healthcare setting, things that they present without a health card and they say they don't have it or they don't know where it is, that should start sending off some alarms as well to you. Okay, so assessments, red flags. So you're already doing so much of this as clinicians in your everyday work, but these are things that you can use in part of your mental assessment with your patient. So presentation, how did they arrive? Did they get dropped off by somebody? Did you see the vehicle that they came in? Was it a nice vehicle versus, not a nice vehicle? Who is giving the complaint? Is the individual speaking for themselves or is somebody else talking for them? Does the individual who presented seem fearful, nervous, avoiding contact? Does the language being used sound scripted, like something that they're repeating from somebody else? So again, this is already stuff that you should be trying to be picking up in your everyday assessments of individuals, but just kind of keeping in mind trafficking as well if you have some red flags going off. Really, screening abuse should already be implemented in your practice as it is best practice guidelines. So you can find more information on this through RNAO, but any female 12 years of age and older should be screened for abuse. I mean, males also need to be included in this assessment. I know from my experience when I've worked in the emergency department at triage, I asked anyone who was over 12 years and older if there was anyone in their life that did make them feel afraid for their safety, and it was quite surprising how many males answered yes to this question, so whether they were currently afraid or had been in the past. So I do think, it really is focusing on women, but it would be, I think wise to not rule out men asking those questions too as well. Social, so paying attention to the types of health coverage that one has. So are they on Ontario Works, ODSP, do they have private care? A big one to pay attention to is, do they have documentation? So again, as I said, when they present and they don't have a health card, that should start, raising some red flags. Do they have a driver's license? Are they holding their documentation, or does somebody else have it and they're the ones who are giving it to you? Do they know where they are, what city they're in, town or province? Who do they live with? Who is their emergency contact? If there was an injury and they said it happened at work, are they filling out a WSIB? So different questions to start thinking of. Okay, so the client, are they dressed appropriate? What do their clothes look like? Are they dressed really, really nice? Or do they look like maybe they haven't showered in a long time and their clothes are kind of torn and battered? Does the injury match the presentation? So classic example, of abuse, as everyone's familiar with, if a female presents with a black eye and says that she tripped and hit her head on a door, right? There's some red flags going off with that. If they have a fractured bone and they said they fell and landed on their wrist, so to, the healthcare providers, that would be a FOOSH injury. And really, the common injuries you would see with that are distal radius fractures, and then ligament injuries. So, if you get an x-ray and there's a spiral fracture present, then that should be setting off some alarms, because that wouldn't match the fracture itself, the mechanism. So different things to start paying attention to. Emotionally, how do they seem? Most people who have acute injuries are usually quite upset, either crying or demonstrating pain in visual ways. But maybe this individual is quite quiet and timid about their injuries, and they may be downplaying what they're coming in with. Is it new or an old injury? And was there a delay accessing care? Are they always worried about where the person who came in with them is looking around for them? The accompaniment, so controlling behavior, is the individual answering for the patient, not letting them answer their own questions or tell their own story? Are they downplaying the injury? Does what they're telling you match what the injury is going on or what the client is saying? And then just asking additional questions, maybe asking for their own health care. Okay, so physical assessment, red flags. So 50 to 60% of cases present with red flags. Healthcare providers are trained to look for red flags, but sometimes we don't question enough, or we feel awkward asking safety questions. And then a lot of times because of that, we don't ask it. So it is so important to trust your instincts. And if something doesn't feel right or look right, start asking questions. And if there's something you're not comfortable with, then, know that about your own practice and try to get more educated on that so that when you do become faced with a situation, that you do feel comfortable asking those questions and knowing where to turn to. So physical assessment, I'm not going to go into too much detail here because there's been some examples in other sections, and Mia's talked about some stuff as well. But again, unexplained injuries, burn marks, cuts, wounds, trauma, neurological, so if they're having headaches, memory loss, high blood pressure, gastrointestinal issues, if they come in with STIs, unwanted pregnancies, genital trauma, foreign bodies, substance use disorder, mental health, PTSD, suicidal, depression, anxiety, and other high-risk behaviors. So, running away, early sexual initiative in a minor, trauma bonding with a trafficker or other victims, delayed physical or cognitive development, and impaired social skills. So again, I'm not going to go through all of those, but those are just kind of touching on some of the red flags. And then the case study I will hand over.
Mia, you might just be on mute right now.
Hi there. So I'm going to pass the phone over to Caroline, and she's going to tell a little bit about her story.
Hi there. My name's Caroline, although usually I only ever was able to answer to bitch, slut, or whore. My husband passed. I lost my husband. I lost my mother and my two best friends within a period of 6 months. And I came, with hindsight, I realized I was suffering from undiagnosed clinical depression and something called complicated grief. I was introduced to a man who I'll call John by my best friend's husband. So initially he came with excellent references. And I would come home and he would have gotten into my apartment and there'd be a new hi-fi stereo waiting for me, or the apartment would be full of flowers. Now you must remember, I was basically emotionally and psychologically a puddle during this time. And he told me that he would take care of me and that everything would be okay. Now I really needed the help and I needed to believe this guy. And I eventually fell for him to the point that within 6 months, I moved in with him. Now, unknown to me, all my savings were being spent, and any sort of social circle that I had, I didn't realize was being eroded. I wasn't allowed to go see people or talk to them or anything. And one day, about another 6 months later, the sheriff knocked up at our door, and we were being evicted. And I was unaware of all of this. And it was at this point that he said to me it was now my turn to take care of the family. So and to go and work in the strip bars. Now, my first sexual assault was at the age of 8. At 14, I was attacked and raped. At 16, I was attacked and raped. And at 18, I was attacked and raped. So by this stage, I had, come to realize that my body was for the taking. This was my norm. So when he suggested that I work in the bars, I was not as shocked as I should have been. So anyways, I was not a drinker, but this is when I started. It was the only way I could get on stage and do my shows and go in the back and be what I call sexually assaulted by customers. And please know when I use the word customer, I'm being incredibly diplomatic. So this went on for years. I'm making a very long story short. And I tried to escape several times, but he always found me. And one of those escapes, I went to the women's shelter, and he found me there that same day and proceeded to throw things at the building. And when they threatened him with law enforcement and he left, they told me I could no longer stay there as my presence there endangered the other woman. They then transferred me to another shelter. 2 days into that stay, I fell ill with what was to become a lung battle with colitis and was admitted to hospital. But I spent 27 hours in the emergency room, and I kept asking the doctors to please call the shelter to tell them what was going on, and no one would help me. And I was pretty sick. and in a lot of pain. And I wasn't treated very well, and they knew I had come from the shelter, and they didn't care. They didn't show any compassion for me. And in fact, because I have tattoos, one of the first things they did was check my arms for needle marks, because I'm not stupid. I knew what was going on. So eventually they couldn't figure out what was going on, so they admitted me. So they put me on the floor opposite the nurse's station because there were no beds. But at about 2 o'clock in the morning, I woke up with my trafficker standing over me. Now, this is right across from the nurse's station. They're watching this whole thing go down. And he gets me up out of bed, puts me in a wheelchair, and takes me outside. And he told them it was to smoke cigarettes, but they should have never let me go at that time in the morning. And so when I'm outside, he's telling me not to talk, blah, 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 watch me back, blah, blah, blah. He takes me back. The next morning when I wake up again, he's standing over my bed again. So how come no one picked up this? This was very odd behavior. I also gave no emergency contact. I had no friends or family visiting, only this one guy. Anyways, they then discharged me. I had nowhere to go because if you stay away from the shelter for more than 2 nights, you're evicted. So I was left standing on the hospital steps with sick, a quarter in my pocket, and nobody else in the world to call except for this guy. Now, the way that the fact that it was a boyfriend that started to traffic me, it's called the lover boy / Romeo scenario. And what they do is they love bombard the girls. They ply them with designer clothing, nails, jewelry, dinners, like weekend aways, and they get the girls to fall in love with them. And this is what happened to me. Like I said, the lover boy scenario. So at this point now, he decides that I'm not allowed to live in a home, that I'm supposed to work and live out of a car. And if I got lucky, he would park the car next to a porta-poo. If he didn't, I was out of luck. And unbeknownst to me, so what they do is they have what's called stables, and they can make like $250,000 a year off of one girl. And often they'll have several girls in their stable. So unbeknownst to me, because he would disappear for periods of time, he was running other women and having sex with them also. And then he would come back to me and have sex with me. And I got very, very sore downstairs and very painful, and I went to a walk-in clinic. And the doctor said, it looks like something's up, but he had to do tests. So when I came back outside to my trafficker and I told him this, he lost his mind and started screaming that I was acting. And he went storming back into the doctor's office, while insisting on seeing the doctor, because he needed to tell this doctor that he was full of you know what. Now, there was another example. They should have called the police. Clearly, I was in trouble. At the very least, I was in an extremely abusive relationship. I could have been rescued at that point, too. And in fact, when I was in the emerge, I had cigarette burns on me. No one asked me about them. I had cigarette burns on my breast. I had cigarette burns on my arms. Nobody questioned any of this. So there were several missed opportunities there. And I know girls, and I knew girls, and I know girls now that can have abscesses that will not go to emergency rooms because of the way they're treated. They'd rather die, literally die. So, and I talk about, I remember one night when I was lying on the floor, because I always had to sleep with an eyesight of him. He woke me up and told me I would never be allowed to sleep again until I took a blast on the crack pipe that was being given to me. So it eventually got to the point where I had to smoke the crack to do the job, and in order to smoke the crack, I had to do the job. And I know, looking back now, that there were people who looked at me who saw nothing more than a dirty crack whore. But what you must realize is it was a journey to get to that point. And in fact, we need to lose the term crack whore from our lexicon, because all you're looking at is somebody who's in incredible pain and potentially in a life-threatening, dangerous situation. So please, 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 if you come across people, try not to judge, put your bias aside, and recognize that this person is probably asking for your help, even though you may not hear the actual words. Thank you. I'm going to pass you back to Mia, sorry.
Okay, and Jenna, I think you're next.
Okay. Thank you very much, Carolyn, for sharing your story. It's very good to hear, especially as a healthcare provider who's worked in the emerge. It does reinforce kind of why we're doing this presentation. So, suspected cases are in consideration. So, if you have a suspected case, things that you need to consider, and these would be best practice. So you need to consider, obviously how to modify them in your own work environment because every place is different. It should always be routine practice to interview a person alone. So as I said before, make sure that, they're by themselves so that they're able to answer questions openly and honestly if they feel comfortable to do so. Meet their immediate needs. So maybe they're really hungry because they can only eat once a day. Then give them food. If they speak another language, make sure you use a proper translator. Don't use the person who came in with them. You may not know what they're saying, translating back and forth to the patient or you. Sit at eye level and be cautious of what your body language is saying to them. Be open with your body. Let them know that you're there to listen to them and not that you're typing on a computer and occasionally glancing over at them, because that's not going to make someone want to open up. Avoid using terms like trafficked, pimp, or sex worker. They may not identify themselves as being trafficked or understand what that means. So this is where the safety questions that we talked about previously would come into play. So, starting to ask some of those questions and seeing, whether or not they're answering yes or no to them. It's important to know that you may only have one opportunity for this disclosure. So it's important, again, to make sure you're listening with full attention. Ask open-ended questions, limit people who are involved in this case, and don't make them repeat their story, as this may re-traumatize them. So again, make sure when they are talking that you're listening to them and you're not thinking about someone else or what else you have to do and typing into a computer. Give them 100% of your attention to let them know that you care about what they're saying. You don't need to dissect their experience or trauma. Just provide care that promotes safety and stabilization. Okay, so if there's a suspected case again, so safety, things to consider. So you may need to consider the danger around the situation, not only for the individual who is being trafficked, but other people who could be exposed to the situation that could cause harm. So you need to find out, if the trafficker is present. Are they in the waiting room? Are they in the next room? What's going to happen if that individual does not return back out to the trafficker? Do they have a weapon on them, such as a gun or a knife, which could put other patients or staff in a dangerous situation? There's that fear that if the individual trafficked does not return, that they're going to be in danger of their family members. Traffickers make sure that they know information about family members, as this can be used as a form of control. So knowing, what time their younger sister gets done school or where their parents live in another country. So, this is a big form of control because they don't want their family to become targets of violence either. So it'll be used against them. So knowing, possibly other people who could be in danger. These would need to be, specific. So things to put in place need to be specific to your organization to end this situation because, again, every place is different, resources are different. So it's important to have safety planning not only for your facility, but also for the individual who's being trafficked. Maybe they're not wanting or they can't access help right now, but you could talk about places that they could go when they are ready or able to in the future. So, again, what's readily available in that community. This is really why it's important to have all healthcare professionals and law enforcement agencies to be knowledgeable in trafficking so that if, say, they went to one emergency department or police, had an encounter with police and they weren't ready, to leave their situation, but then later on down the road they know that, okay, if I go to this place, I'm going to get help, I'm going to be safe, that they're actually going to be cared for properly. So that when they do show up to have, that disclosure, that help, that they're cared for. Okay, so action. So one important thing to note is that the legal age of the individual. Okay, so if they're under 18 and you're suspecting them being trafficked, then you need to notify CAS and. Yes, the reporting for CAS normally is under 16, but someone who is under 18 cannot legally consent to being trafficked. So if they're older than 18 and they're, choosing to stay in the situation versus if they're under 18, they cannot consent to being exploited. So again, if they're older and they don't want your assistance, then that's their choice, okay? It's important, though, to know what resources are in place in case you do come across an individual who is wanting help. So really the patient is a driving force behind the care that they're receiving. You know, if they want police involved or to be seen by a sexual assault forensic nurse examiner, you know, what about their immediate care is met, and then what? So what are they wanting? What do they need? This is important to establish, you know, why it's important to establish, a single point of contact for this person. So this would be someone who could help coordinate services for them, you know, go to appointments with them, advocate and communicate for them. You know, there needs to be consistency. Most of these individuals have not had consistency in their life or in their current situation, you know, so being that consistency for them is going to make the difference, because it's going to help try to prevent them from falling through the cracks of the system. Okay, so short-term comprehensive care. So again, client decides what is priority. So this is just showing the different areas of care, and that it's important that the client is the one who decides what they want. You know, is there immediate danger? You know, if so, initiating law enforcement. So again, immediate danger means different things to different people, so sometimes this does come down to a judgment call. Safety planning and assessments. So we just went over this in the previous slides, but meeting basic needs. They may want, you know, food or a shower, so, you know, that may take priority over everything else. Sometimes it may be, you know, they may be concerned about their status. So if they're not a Canadian citizen, they may be afraid that if they get help, then they may get deported. So this is important to know who in your community can help answer these questions and help protect these individuals. You know, and immediate needs. So sexual assault nurse examiner RNs, social workers for forensic evidence collection, you know, Plan B, STI screening, post-exposure, antiretroviral, and testing if desired, with counseling, wound care, and unmanaged chronic illness. So as Mia talked about, you know, maybe they have, you know, diabetes or, you know, hepatitis, and who's going to manage these, or how are they, you know, getting that chronic care. Needs understanding substance use, and that many individuals who are trafficked may have some form, you know, of addiction, whether it is drugs or alcohol or both. So, you know, what are you going to do then? They, you know, to do an emergency care on these individuals is fine, but then what kind of care are they going to have afterwards if they go into withdrawal, and who's going to manage that? You know, a big one is, excuse me, that is shared throughout the literature is the mental health, such as anxiety and depression, PTSD, and who's going to counsel them, that trauma-informed care. You know, it states throughout the literature, again, that there should be trauma counseling offered to these individuals, as some may have had, you know, trauma that goes back prior to them being trafficked, and that is something that also needs to be addressed. And I'll turn it back to Mia.
So what would you do if you had a suspected case? So what would some of the actions be, or some of the considerations be? Well, the first thing you would want to know, and I encourage everybody to go out and seek this information from their organization before they interact with these persons, is, does your organization have a policy to manage trafficked persons and to identify them and give them kind, considerate, and compassionate aftercare? So a hospital in Boston has actually created a healthcare provider guide on how to work with trafficked persons and what their organization would advocate for if somebody were to be identified. The other thing to keep in mind at this point is to know whether or not your community has specialized police services for trafficked persons. Many cities do actually have these specialized police forces, and they go by many different names. But if not, police forces are starting to have at least one or two officers who are kind of well-versed in this area. Does your community have an anti-human trafficking group, and is this something that you would want to join as a healthcare provider? We know there's not a lot of healthcare provider representation, but there's easy ways to find it if your community has this, and there's a couple links below. And then, is there appropriate housing available in your community? This is one of the major barriers to providing ongoing care for trafficked persons, because we know that many housing situations may make people vulnerable again, or just aren't appropriate for trafficked persons. Now moving on to healthcare-related aftercare. So this would be for anybody who is in primary care currently or might be in community health care and would be managing people after they've been identified. So there's two situations that could happen here. So they might be still being trafficked, but receiving health care from your organization. You would want to be able to work with those clients. Or they might be out of their trafficked situation and be somewhat safe, but now there's a whole slew of clinical issues that we would need to start to address. So please provide compassionate primary care and ongoing care, and really self-reflect when you're working with these people. As Jenna mentioned, determine which issues the clients want to address first, and then in what order would they like to address these issues. From a preventative health perspective, there are many ongoing things that we could consider. So are they having some of these somatic symptoms like headaches? Is the result of a concussion? Do they have vision issues? Do they have emergency dental issues? Further down the road, we might want to think about immunizations, getting them up to date on their cancer screening. One thing that is obviously quite prevalent in sexual exploitation situations is managing reproductive care and curing STIs if possible. And then again, on the long-term relationship side of things, to address unmanaged chronic illness and to move forward in that way. From a mental health perspective, there's obviously perhaps a lot of work to do there, and making sure that that person has access to trauma-informed counseling, whether that be through a social worker at your organization or community supports. And many communities are starting to have more trauma-informed counseling available for trafficked persons. And then finally, to assist them in seeking whatever form of substance use assistance they require or prefer. So this slide is a fairly complicated slide, but it really highlights a couple things. So this slide is a study from 2015 and looks at why challenges occur when meeting the mental health needs of trafficked adults. So how and why do they happen? So after somebody has been identified and enters the mental health system, how could this actually make them more vulnerable to being trafficked? Well, one thing is that there's a lack of engagement for that person. Another big issue that we see is difficulties with interagency relationships. So who's responsible for the person's care? Is there a lack of communication? On the flip side is, are there even any services available in that community? We know that all of these things, including unstable accommodation, difficulties getting the full story, do lead to ongoing risk of sexual exploitation and harm. Finally, I want to talk a little bit about a long-term comprehensive service plan. And this is quite a complex slide, but it does highlight the Austin and Boyd model of the biological, social, psychological, and spiritual piece that is all of us. And this service plan is created based on the MCIS Languages Services document on how to work with trafficked persons. So just as a couple examples, from the spiritual perspective, for example, does this person feel connected to something? And so on and so forth. And you can see there are many things that are going to come up as priorities, and again, just to manage them in the order that the person prefers.
That's great. Thanks, Mia. So we're just going to turn it to the other portion here. So Mia, you're still the presenter, so if you just want to click on the top there, HT_PT3_A3, great.
Just to wrap things up, I want to leave you with a few resources for online trainings that you could engage in if you wanted to know more. And these are excellent trainings. So the one on the left is by Fraser Health in BC, and they actually take you through trafficking situations and some of the red flags that you could look for when looking at trafficked persons. And these are really good trainings because they're not always the sexual exploitation case. On the right-hand side there is the online training I was mentioning to address human trafficking by MCIS Language Services. There's also a subset of trainings just for healthcare providers. And the really great thing about this document in the PDF version is No matter what community you're living in, there are listings of different agencies to address different needs of trafficked persons in various communities across Ontario. A few other things that are happening in this world is that many cities are coming up with community-based hotlines. So if you're a healthcare provider and you're not too sure what to do, maybe you think you've identified a trafficked person, maybe they're still in your clinical setting or not, this would be a way for you to access some resources. So Winnipeg has an excellent community-based hotline. London does. Toronto is working on one. And obviously, I encourage all of you to start one in your community. There are some hospital-based hotlines. So Fraser Health has one. And that means that any healthcare provider or any community member in Fraser Health, including victims, can call this hotline. And this hotline directly links to the forensics nursing organization in Fraser Health. And then finally, we know that there's perhaps going to be a national hotline for a coordinated response across Ontario. Finally, some exciting news at the provincial level is the provincial government has now noted that they're going to contribute $72 million to addressing human trafficking in Ontario. And some of that money is going to go to our LHINs and hopefully be dispersed to provide further education and training to healthcare providers, as well as community initiatives to provide aftercare. For my piece, I'll just say a special thank you to the RNAO for inviting us to speak and giving us this opportunity to discuss this to all healthcare providers and service workers that are interested. Of course, you, the audience, and then Tara Wilkie, who is an RN from Fraser Health and did develop that training I previously mentioned, who helped us put together some of this material. We also have a list of all of our contact information there, and we are all open to receiving questions and comments, both about this talk, as well as how we could make it better in the future, and if you have any specific questions about working with trafficked persons, we'd be happy to respond to those also.
Great, thanks so much, Mia. I did want to take a moment to echo some of those thanks to the audience, as well as the presenters, so yourself, Mia, Jenna, Carolyn, and Julie, for taking the time to present this insightful presentation and information. So great to hear about that $72 million that the province has recently committed to supporting this cause. For more information, I just wanted to direct everyone to the RNAO website. It's rnao.ca. If you wanted to access any additional information, resources, or guidelines, or alternatively the specific mental health and addiction webpage, which is rnao.ca/mental health. And once again, thanks to everyone for listening and our presenters for presenting. And thanks, everyone, and have a great day.